Good afternoon, everyone. Thank you for joining us for today's Endocrine Grand Rounds. Today, we are very happy to have Bryan Glaenzer talk to us. He is from the radiology department. He's assistant professor of radiology at University of Louisville. And he's also the medical director of the interventional radiology at the VA Medical Center. He graduated from University of Illinois Medical School, and then did his radiology training at Rush and fellowship in interventional radiology at Washington University in St. Louis. He has been at Louisville since 2019, and his interests are in interventional radiology. And for some time, we've been hearing about this procedure, radiofrequency ablation of thyroid nodules, and it's new and something that we would like to learn a lot more about and see where it fits in our practice and how to use it. So we are very glad that Dr. Glaenzer has found the time to come here and talk to us about it. Thanks.
Thank you. So hi, everybody. I'm Bryan. As you said, I've been here for about 4 years. And I've been trying to, bring new and fun things. You'll kind of see what my peers do in just a second. This was the thing that I was kind of hoping would keep everybody interested. This is the case that we purchased the machine for, and that was pretty exciting right there. Mostly because it was my first one, and because the carotid was right there. But that's what it looks like when the RFA probe is actually on. It's cooking the thyroid cancer recurrence, yeah, that was pretty exciting. I'll have some more pictures of that later. Who are the attendings here? I actually have no idea who many of you guys are. So obviously I met you, Dr. Mushagundam. Endocrine? Excellent. Endocrine? Yes. Excellent. Okay. Yeah, it's going to be fairly pertinent for you guys because we can maybe avoid some radiation this way. So anyway, this is my first case. My heart was somewhere around that of a hummingbird's when I was doing this one, well, now it won't go forward. There we go. All right, so I have nothing to disclose. This is my Sunshine Act. I wanted to prove it to you guys that I have nothing to disclose. So I'm below the US mean and my specialty mean. So I don't know if you guys know that, but you can look that up for anybody. If you ever have any sneaking suspicions about someone, you can always go do that. So this is our department. I don't know if you guys know who we are. So that's Dr. Sohail Contractor. He is our new chief. I was here actually about a year before he was, and then I bought a house when I met him. He's a great guy. He was from Rutgers previously. He is both the chief of IR and the chair of radiology. So he's kind of like my double boss. That's what I looked like before I became an attending. My peers apparently decided not to follow suit with the no suit coat. But then you see Dr. Ba right there. Some of you probably know Dr. Ba. He does our kyphoplasties and adrenal vein samplings. This is Dr. Chorney. He is kind of a jack of all trades. He's trying to do some prostates as well, embolizing prostates. We can do that. Turns out that's safe. And then Dr. Ghazi. He is same year as Dr. Chorney. He actually did a surgery residency, part of a surgery residency here, and then converted to radiology. And now he is one of our partners. And then Dr. Pretty is another resident who did surgery for, I believe, 2 or 3 years, and then transitioned to radiology. Dr. Contractor does all of our tips and biliary work. Dr. Chorney, as I said, goes after big prostates. Dr. Ba, this was one of his 4 levels. And this is a case Dr. Ghazi had just the other night, 80-something-year-old lady who had a pseudoaneurysm of a profunda branch, and he embolized it, as you can see there. A little bit about me. That's my dog. That's Dr. Ba and one of our residents going at a cadaver course. We're bringing a genicular nerve ablation. So this is not the only procedure that I do that's different and new. You can actually burn the nerve to the knee, and it can treat knee pain. We can also embolize the artery to the knee. Dr. Mashkundam, similar to what you were talking about, that one's not reimbursed by insurance yet. So I'm doing it over in Lexington. And then these are two more residents. We take PEs and DVTs out. That was some clot that we had. I do things besides interventional radiology. This is down near Bon Air. If you have a chance to go scuba diving, you should. The reefs are going to go away at some point. And radiology art. It turns out you can make the flowers suck up iodine the same way that they can suck up dye. And yeah. So what are we here for? So we're here for, let's talk about the TIRADS a little bit. TIRADS is the new way of describing thyroid nodules. I just wanted to briefly touch on it. It's pertinent for all of you guys. They used to have all kinds of different ones, but now we're trying to commit to TIRADS. TIRADS is kind of like they came out with BIRADS. So mammography used to be just the Wild West, and now they've kind of routinized it, and they're doing that to the thyroids. Thyroid nodule treatment algorithm, that's pretty brief. It's basically just the Bethesda system. And then we're going to go through the workup, complications, what you can do this for, what you cannot do it for, and then hopefully I'll not be so long-winded. You guys can get some questions. So the TIRADS, this is readily available. If you ever have any questions about us doing these things, there's also a TIRADS calculator, and you can kind of click through these things. Cystic, spongiform, mixed solid cystic. Basically, if it's black, it's cystic. And then if it's a lot of black, it's completely cystic. If it's not a lot of black, it's either solid or spongiform. Spongiforms look like sponges, oddly enough. Echogenicity you compare to the strap muscles and the thyroid parenchyma shape. If it's taller than wide, it's growing against the tissue planes. That's why they give you so many points for that one. Margin, that's pretty, I think, straightforward. And then depending on how many points you get, you add them up, and then it tells you what to do depending on the size. This is the, for the surgeons, I didn't know if there was going to be any here, so I wanted to be prepared. I also didn't talk about their complications, so I watched out for that. But basically, if it's benign, you watch it. If it's anything other than benign, you either FNA it again, watch it, or cut it out. And maybe we'll start changing that. So this is the workup. For all intents and purposes, the workup is you FNA it twice because we want to make sure that it's not cancer before we cut it out, before we burn it. Because once we burn it, there may not be any remnant left behind. Unlike the surgeons, when they cut it out, they can show it to the pathologist afterwards, and they can say, oh, there was cancer in here. We need to do something about it. Well, you can't do that with this. And sometimes the cells come out kind of funny looking when you burn them. So if you FNA them after you burn them, it's considered a no-no. So you don't want to do that. It gives you some kind of squirrely results. So you want to do all your due diligence ahead of time. If it's very benign looking, like it's a spongiform nodule, you can get away with maybe one FNA. But otherwise, you do the ultrasound as you'd expect. You multiply it by its length, height, and width times 0.523. That's just the number they have. They have a cosmetic score. That's right here. Had never heard of this before I started doing these, but that is a thing that we'll probably be more familiar with going forward. And then if they have like a big multinodular goiter, or it turns out to be cancer, I would get a CT scan or MRI to see if there's anything that extends substernally. And then if it's autonomous functioning nodule, obviously you'd need to get some scintigraphy that I'm sure you guys are very familiar with. Complications. So the way that they do this, not that you guys maybe are going to do this, but if you want to do it, they call it doing a They call it doing a transisthmic approach because what you're trying to do is stay away from their recurrent laryngeal nerve. Okay, so if you come into it like this, they're worried you're going to hit it. So you go into it through the isthmus and burn it this way. You're only supposed to do one side at a time so you don't lesion both recurrent laryngeal nerves at the same time. And then the vagus nerve running in the carotid sheath is also something that you're worried about. The main complications are not getting an effective ablation. The lesioning the recurrent laryngeal nerve, and hematoma. So this, it felt like when I was studying for this that it was shouting at me when it would have this massive wall of text, but it also was such a nice thing. Basically, all of the different associations came together and made some guidelines together. The most important, surprisingly here, are the Italian ones. They've been doing a lot of work on this, and the Korean societies. The Korean societies have been putting out guidelines for quite some time. So I gave all of you guys these, so you don't have to go over these with me. But these, the first about 4 are the most important ones. And then after that, it kind of gets into the more minutia for the person who's going to be burning these. But basically, 1, it's an alternative to surgery with benign nodules who have compressive or cosmetic symptoms. Okay, so if they have globus, like they feel like they're swallowing something, or they're just worried about how they look, send them to us. And if they don't want to go to surgery, okay. It is less efficacious for surgery than surgery or radioiodine, but we can treat autonomous functioning nodules. And then also, if you have papillary microcarcinoma, okay, so none of the other ones other than papillary microcarcinoma, we can treat that as well. And the outcomes look pretty darn good for that. Our lady had papillary carcinoma. We can also treat recurrences, the lymph nodes. We can burn those as well if they so choose. If those pop up and they decide that they don't want surgery or they can't undergo surgery. Again, you guys can see these. These kind of get bogged down in the minutiae. Workup, complications, indications, and data. Okay. Although less efficacious, I think personally and professionally, the autonomous functioning thyroid nodules is going to be something of a sweet spot for us because it's going to be actually curative once they get somewhat better at the technique, and it's actually going to be doing something as opposed to just going after the cosmesis. Okay, so Vu et al. In 2022, these are all very recent papers, had 17 people. Predominantly in a single session. You'll see some of these people, they'll come back and do a second one. That's because sometimes you don't get the artery, basically. And now they are counseling people to go after the artery first or the vein first to kind of devascularize it. They gave a 24-month follow-up. This is going to be important as well. The reason why that was on the pre-procedure workup of this, which seems kind of esoteric, is because they've correlated, and I'll talk about this later, they've correlated the outcomes with size. So 100% were euthyroid at 24 months. That's pretty amazing. I find that somewhat hard to believe. I would take that with something of a grain of salt. It is not, I was not familiar with this journal, Therapeutic and Clinical Risk Management. I assume that it's not published in one of the bigger publications because there's problems with it that I didn't appreciate, but 100% is never real, right? Like that's pretty crazy. So that being said, here's the symptom score that the patients had, and it went down appropriately. The TSH came back up appropriately, consistent with them being euthyroid. Also, the mean volume regression is going up. They've lost a ton of size, and the volume went down. So that's pretty nice. 2019, Servilli, they took 22 autonomous functioning nodules and then compared them to 25 similar patients who had radioiodine. You guys are probably much more up on this than I am, but basically functionally 72% became euthyroid with radioiodine, 90% became euthyroid with RFA. So again, these are great results. I would expect that some of it is going to be moderated by, this may be exuberant. Everything kind of follows that pathway, right? Like it's like the best thing ever. And then they tell you never to do it to anybody. And then it turns out it's good for some people and sometimes, but it seems quite good. And these are all statistically significant. Okay. The American studies. So maybe they were doing something off somewhere else and, it wouldn't stand up to the light of day here because good old America or something like that, right? Well, they have 3 patients, Candle, 12 10, and 40. 40 is huge. Okay, so the 13 is about the critical threshold beyond which things start to work worse. 2 patients became hypothyroid at 1 month, and then all of them were euthyroid at 3 months. So this person had no other experience doing this. I like to think that I'm pretty good, but I realize I've just done 1, right? It is reasonable, therefore, to suspect that I would have similar results. Hussein, he had the largest trial thus far in America. The accrual time is still quite recent, 20 patients. We do not have long-term outcomes, as you can see, because it's so recent, but 15 of the 20 became euthyroid. Here is the Hussein data. So 8 were on methimazole, and then 6 were on methimazole afterwards. However, I'll let you read that. So he was able to get most of them off of methimazole is the point here. So that is, I would say, quite successful. These are statistically significant, obviously not the methimazole, but there should be an asterisk after that. Cesario. So this is I think another really good study. So this is the one where they kind of tried to figure out what was going on here. 15 patients with a autonomous functioning nodule less than 12 milliliters in volume and 14 greater than that. 86% of the small nodules, so that's the less than 12, converted to cold, whereas 18% of the larger nodules converted to cold. I am more willing to believe this because it seems more realistic that, you know, despite your best efforts, 85% of the time it works out. So I'm hopeful that that is going to be the case. And then keep in mind, you know, you could come back and do these again. This was all just a single session, right? So if you do not succeed the first time, you can go through rounds and rounds of it. For our pediatric colleagues, you wouldn't want to do that with radioactive iodine 131, giving them rounds and rounds of I-131. I wouldn't think. Again, I do not prescribe that, so I'm not sure. I had my nuke med rotations, but I have stopped using that. And here you can see the data. You can see the TSH for the group A, the small nodules. It increased and it became statistically significant versus the group B. And you didn't see much of a change at 1 month, but you do see a fairly significant change that's statistically significant at 6 months. Now the error bars do overlap, so you know we have to keep that in mind. Solid non-functioning nodules. So ultrasound-guided ablation procedures may be used as a first-line alternative, which I guess is first-line then, if it's a first-line alternative. Patients with benign thyroid nodules contributing to compressive and/or cosmetic symptoms. So Cho has a really good systemic review and meta-analysis, and they compared the radiofrequency and laser. I wouldn't have put this on here if it didn't show that radiofrequency was better, and radiofrequency showed a 92% regression in size. Okay, so you can, if you don't get your results the first time, you can repeat it again. There's no downside with that. You can even have them come back and do surgery afterwards, right? There's not really a downside to doing this kind of a thing. And you can really go after some big ones as long as you counsel them that it may take several times. Jiang et al., 55 patients underwent RFA for a solid, benign, non-functioning nodule, and 47 of them were in a single session. This was more to show their quality of life increased and the tumor size decreased in size. So it went from 21 down to 5. That's pretty impressive. They also lost, 11 people, which is a little bit of a bummer in a study that small. But their cosmesis score decreased significantly, and then their symptom score also decreased significantly. They did have some pain during the procedure. I did not mention that earlier. These are actually just lidocaine procedures, which is pretty crazy. I did my first one under anesthesia. That is always an option. But the idea is actually you want to have them under local anesthesia or moderate sedation so you can talk to them if they start having any pain or they start having voice changes. So you can monitor them during the procedure. Once you get inside the thyroid capsule, there's no nerves there, so it doesn't have any problems. Okay. Also, we use I don't know if you guys know how they do varicose veins, but they put in some very dilute lidocaine. It acts as a heat sink, basically, right? So you surround this thing with water, and the water has a high specific heat. Takes a long time to change temperature, and it can suck up the heat if it gets too close to any kind of important structures. So that is one of the ways that we can do this with just lidocaine, which is pretty amazing. And I can speak to that. We do liver biopsies all the time, and they only have pain when you go through the capsule. After that, they might jump when they fire the gun, but otherwise they don't have any problems. Thyroid cancer ablation. So I want to be very specific here. Only primary papillary microcarcinomas. Now, how are you going to find those if our TIRADS guidelines tell you not to biopsy the small ones? That's a little bit of a conundrum. But if you've biopsied them and you have a micropapillary carcinoma, I would be very happy to go burn that for you. But we need to make sure there's no distant mets, because we won't see if there's vascular invasion or anything like that. Also, we want to go for them that are inside the gland. If they are pushing through the capsule, that would be something I would much prefer to have a surgeon go after until there is more data to suggest otherwise. Show again, this guy was pretty impressive. 84 nodules in 74 patients. 2 ablations in 13 of the nodules. This guy had a disappearance rate of 98% at 24 months, and he followed them for 60 months. That's unheard of in American data. It's very impressive that they have 5-year out data. One patient did have voice change that resolved in 2 months. So a lot of times you will see 1.4% thrown around in a lot of different studies for the complication rate of this procedure. This is the study that they're referencing. This is like a seminal study in this area. 1.4% is 1 person out of the 74 that had a voice change that did get better. And then 4 new papillary cancers arose, and they ablated them. So they took care of all of them. So they're functionally taking care of it for these guys. Another show. Oh, sorry, going backwards. These are the. You guys don't really care about this, but here's the 2 sessions, and you can see the size. They're quite small. Obviously, they're microcarcinomas, and yeah, the power. Again, I wouldn't focus on that too much. The reason that I thought this was interesting is if you follow these guys with ultrasound, the cancers actually swell. That is not an artifact on there. It actually got, the mean volume reduction went negative. It got bigger, and then it gets smaller. And then it kind of asymptotically goes down over time. At 2 years, it doesn't get any smaller. So here's our case. I wanted to show you guys this. So this is the, I thought about this a lot. I figured I'd make you guys think about it for a second. This is our patient CM. She is a late 60s white female, had her total thyroidectomy. The ENT surgeons did not want to operate on her anymore because she had they'd already gone in, and I think they had done a redo as well. So they said, it's a hostile neck. We don't want to do anything. See what you can do. So we bought a machine for this. And by the time we finally got the machine, it went from a small thing to a big thing that was touching the carotid, which was very frustrating. So I hydrodissected it off the carotid, which is a fancy way of saying I put a needle between the carotid and this nodule. And you can see a little video here. The nodule's right there. Okay, and I just injected the saline until it pushed itself off, and it worked out well. I didn't really have much of a plan if it didn't push off the carotid. I was just going to partially ablate it. It is not. No, it's a recurrence. So that's the other kind of wiggle area, is that if it's a recurrence and the surgeons deem it inadequate, they basically give you carte blanche to go in and do whatever you want to do. I don't know why you guys would see people that are not thyroid, people, but we could also go after any kind of nodules in the neck. It is also approved for anything outside of that. This is not yet. I mean, I can burn anything. If you want me to go in there, like I did this, right? Like, let's do it. But that being said, I only want to be so much of a cowboy there because these are, it's people and it's a problem. But if you have something where the surgeons say we can't do this and I can see it, we can try it. We have the ability now to go after it. We have a different set of tools. So this is not wanting to let me go forward again. There we go. So here's, these are still, oh, no, it's not a still. This is another one where I'm cooking it. So the moving shot technique is another thing they talk about. So every other time you guys have heard of any other kind of ablation, you put a needle in and then you turn it on and then it's done, right? That's how we do everything. Well, in this one, you're supposed to have it off as you go forward and then you turn it on and pull it back because you don't want to have it slip while it's hot to go into anything. And you have to go through it in different quadrants. So you do the deepest part first, because as you can see, it vaporizes this the tissue and causes some gas formation, and then you can't see anything deep to it. So you have to go south to north, deep to shallow, and take it out. Here you can see this is me trying to show, one, that the carotid doesn't have a pseudoaneurysm, two, that this thing is dead. There's no Doppler signal coming from it. And then this is a little charred hunk right there. That's about it. So what is ablation not for? Other thyroid cancers and cystic nodules. Cystic nodules, we can ablate those with ethanol. We give them 100% alcohol, and if they have any pain or leakage, we can come back and try to do something else. We can sclerose them, but that is the same technique we'd use for splenic cysts, liver cysts, what have you. And the RFA does not work for this. Also, I should mention, this is RFA. A lot of people refer to everything as RFA, and there's microwave, RFA, and laser. So laser is obviously light. RFA is a switching of the electrical current in such a rapid fashion that it causes heat, and it's frictional heat, and you can char things. So it actually heats up quite slowly. It's an older technology than microwave. Microwave is what we use to cook HCC tumors in the liver, and that can burn quite far. It uses a electromagnetic wave that goes back and forth, causing the water molecules to switch polarity rapidly, and that's what causes the cooking. The RFA can cause charring, and it heats up much slower, whereas the microwave can cook much farther and is much less susceptible to heat sink. Again, I don't know if anyone's going to ask you that, but if they do, now you know. Takeaways here, radiofrequency ablation is a reasonable alternative to surgery in benign, non-functioning thyroid nodules, autonomously functioning thyroid nodules, papillary thyroid microcarcinoma, and nodular thyroid cancer recurrences, thyroid cancer recurrences in those who are not fit for surgery or who refuse it. And then complications are rare, but they include hematomas and injury to the recurrent laryngeal nerve, which would be voice changes or inability to speak if you lesion to both of them. I have quite a few works cited on here. What kind of questions do you guys have? Yeah, please.
You mentioned hematoma.
Mm-hmm.
Anybody develop like thyroiditis sort of,
None that they've talked about thus far. So in all of the studies, so they always they always list all of their complications, and none of them had any reference to any kind of a post-thyroiditis storm, anything like that. They had one hematoma in the surgical literature, but usually it was limited to pain and recurrent laryngeal nerve injury, which is, again, surprising because you'd think that you would set it off too much, right? Also, there was no instances of them going hypothyroid for longer than just a transient period whenever they took out the autonomous functioning nodule. versus surgery where they would sometimes take out the whole lobe or the lobe and the isthmus, and they would make them hypothyroid afterwards for some significant period of time. Oh, sorry.
Other question was, these are mostly, and I know we have discussed about it back and forth in the past. You routinely require that they get a CT neck substernal because sometimes we are surprised that.
Only if I can't see them. So if we're going to go after like a multinodular goiter and we're kind of just trying to debulk the thyroid, which is something that I would be definitely interested in doing. I know I've seen several people that kind of have these big kind of bullfrog necks and the thyroid extends down. The benefit would be is you get a CT scan ahead of time to see what's going on. And then you can take out the visible portion of it and it will scar up. Okay. And then you can take out more of it as time goes on. So you can debulk these. Now, obviously, it's going to be more effective for the smaller ones because 12 milliliters is the critical threshold. But if I believe that if you go after the arteries, you would be able to devascularize it pretty impressively and really debulk some of these guys that have the big compressive symptoms.
They did see, like in the past, the Korean literature, which is where all this started a few years ago. So that they went for a substernal, and there was a small group of patients that they had, because one of the things that happens typically sometimes is you have a patient in their 80s or 90s coming in with stridor, had this huge goiter, didn't get it worked up or refused treatment prior, and now they're two not surgical candidates anymore, and there's not a whole lot to do, but they have stridor. So, and I was just wondering about substernal, because you can only ablate the one above the sternum, and then anything below that, you just hope that
it usually, so from what the literature describes, again, I have no experience in this, but they scar up and then you go and ablate it again. You were mentioning earlier the complications. There is a delayed nodular rupture in their literature. I've seen maybe 2 of those, and that happens at like 2 weeks. Very strange. Must have to do something with the healing process there, but that seemed to be something unusual. I thought there was going to be some ENTs here. That fish reminded me of somebody with parotid tumors. That was why that guy's. What's that? I'm sorry.
We did share.
Huh.
You want to do them simultaneously.
Mm-hmm.
So how long do you need before you get to the left side, and how long do you need? Right.
So there's no indication of what that time is. If you had somebody that was incredibly motivated, there's no reason why you could not just like do them one session in the morning and one session in the afternoon, because you just need to make sure that you didn't lesion the nerve, right? So as long as they're walking around, I mean, in the first, until I've done 40 of them, I'd probably make them wait the next day, just to make sure that they don't get any kind of edema or anything like that that's delayed and causes some problems. Because you always want to be more. You can always be more bold later, right? But I would wait at least a day. But I could imagine a world where if you're going after something that's isthmic or very superficial and it's not near the recurrent laryngeal nerve, you just need to give them some time to say that they walked around, didn't have any problem, and then you could go back and do the other side.
And the concern for fibrosis in the long term, and I say that there aren't many studies to look at the long-term data, but whatever there was, is there any concern for fibrosis?
Oh, so that's a great question, right? Like COVID could make all of us infertile in 10 years, right? Like we have no idea. So they've invented this. It's been out, I think 2012 is the oldest guidelines I've seen. So theoretically, it was probably around for about 5 years before that, 6 years before that, right? Before they had to come up with some guidelines. So it hasn't been out for that long, right? There's no, there's no indication. There was a paper that was looking at these to make sure you weren't giving them cancer, that the ablations didn't cause some sort of like, problem that nidus that got bad afterwards. But there's no way to answer that question yet. No, there's no reason to suspect that. Like they haven't been widespread reporting this. I would suspect that the East Asian countries that have better socialized medicine than America does would be able to have good surveillance on this. But that is an open question right now.
And then last question.
Yeah, please.
Are there any studies comparing alcohol ablation versus radiofrequency ablation?
Yes, and I didn't include that, but it is inferior. So alcohol ablation, it depends on what you're talking about. So alcohol ablation is superior for cystic nodules. What you do is you aspirate it all out and it collapses, and then you put in 50% of the volume that you put in. Same thing that you do for any other kind of cyst. For the RFA, it takes too long to heat up all that water, basically, right, to burn it. And then you can do ethanol ablation for solid nodules. The problem is that it leaks around. It doesn't stay in that one area, and it causes relatively significant pain, and it can get into the vascular system. Alcohol causes coagular necrosis, and it also causes thrombosis of the blood vessel that it's adjacent to. So they had to invent this basically because alcohol was ineffective, if you want to think of it that way, for solid nodules. But you can do that. People use alcohol to ablate liver tumors because it was all they had, right? So that is a possibility, but it's just not as effective or fast as the other techniques.
Talk about the 13 ml, that's the volume, right?
Yeah. No, that's my problem. If you want to send them to me, if it's more than 13, I would just say that it's going to be probably more than one session, is what I would suspect. Is that a lot of these papers would specify whether they did one session or several sessions, and that's the difference there. Is that one session, it's great to crow about if you get it done, but really what you're trying to do is finish the problem for these guys, right? And if it takes you 2 sessions, that's fine, right? It just takes a little bit longer. I don't know how the billing is going to work for that, but because you could see an unscrupulous person would do that intentionally, but I don't see any reason why that would be a problem. As far as I know, they are. So there is a company that is like the company. It's Taiwoong is the name of the company that we got our ablation machine from, and they have another company that you can call. It's actually just Taiwoong and like a fake mustache that tells you how to bill for these things. But they do all the stuff. They have obviously they have a committed interest in doing it, and they work as hard as they can for you. It bills like a liver ablation. So it is probably going to get its RVUs cut going forward because it bills very well, actually. But it's a little convoluted process. You don't have to worry about it, but it is billable right now. Yeah.
Check it again. Okay.
So that is something that we can come up with. So everyone has their own guidelines right now, and no one has an idea. 1 month, 1 month. So they all suggest that you give them, you call them to follow them up, and then do a 1 month follow up. Some people say 2 months, but definitely 3 and 6, and then following out after that. But whatever we feel like is right, I would follow your guys's desires, because it's a cooperative kind of a thing, and quite honestly, I'm interested in seeing how my patients do, right? So I resist the urge to ultrasound them all the time, because you need to give them some time to heal and regress and scar down. But I think 1, 3, and 6 sounds reasonable, and then you can modify that as needed. And then as the article. It came from an article, I didn't show you guys that, discussed, we can also decide how we want to go with like the TSH, T4, T3 scanning, and like what kind of pre-procedure imaging we want to do. But the only thing that I would insist on is something, if it's going to be something I can't completely see on ultrasound, I'd want to have some kind of cross-sectional imaging. If it's a child, I understand doing an MRI instead of a CT scan. But that's about it. We need this cosmetic score and symptom score that can be gotten in the pre-procedure conversation ahead of time, just for, scorekeeping, just to make me feel like I'm doing something reasonable and good. But yeah.
Adding like sending fair you start following them between appointments and do that side.
Yeah, that's not, so we only have one right now, and she, and I am, anxiously waiting for time to pass so I can see how she does. But
A lot of different
I
different aspects to follow, and then like the cosmetic score. I've never calculated one.
So I don't want to steal your patient, but I do want to have as much ownership of the issue as possible. So I could see that going both ways, right? Like I want to have control over that, but it's definitely your patient, right? So I want to be a good neighbor, but I don't want to go too far, right? So I would be willing to have clinic with you guys if that's a thing that you guys want, and just see them with you, or I could have my own clinic and have them come in. And yeah, we can invest in one of those little butterflies. The private lab that I work with has one of those on an iPad, and you can just kind of get a quick and dirty look. Or you can, wheel the full on like machine over there. But I'm open to that as well.
Another suggestion I have is like all these things you have.
Mhm.
So, I mean, our endocrine group, and the same thing goes for the AVS when we are working with Dr. Paula over the last. Here is the different things that you need.
Mhm.
So in Cerner, it's best for Kinetic to build something where we open for a consult for this, that all this drops down and everything has been done. So to your satisfaction, rather than just them.
That's a brilliant idea. I mean, obviously but I would have no problem.
Because
I don't
you
know.
may get consults from.
Yeah, and then you can just click thyroid ablation consult, right? And it says something to me, and it orders a CBC and an
Yeah, just the
ultrasound.
criteria, just like we have.
Yeah, that's a great idea. That had not occurred to me, because I'm still, excited and not looking at this as a.
Are there any questions there?
If there are, I've been ignoring them. I'm sorry, what? Oh. That's me, I think. That's a transcript of what we're talking about. That's okay. I didn't know it could do that either. I'm gonna have to.
Oh,
Work on the hairline.
that's Teams, I forgot. in chat.
Yeah. Do any of you guys have a?
Chat thing there. Records everything. Talking.
Oh
See, yeah. Did I ask you a question?
no, they said they couldn't see anything. That's a bummer. Oh, I didn't share it, did I? Ah, son of a. Did I? I thought they set me up. I think I had to do this. Oh, okay. Oh, good. Okay.
Yeah, usually they texted one.
Yeah, I didn't.
Okay. Yeah, that's a great idea. I don't know how to do that myself, but I will have one of my residents work on that so we can have like something in Cerner.
So Josh Seekman can help with the AVS, the whole thing for us. So he's the informatics person.
Oh, great. So I was mentioning that I was doing this today. Dr. Dada, do you know him? He's the IR, the VA radiology chief.
Yes.
He looked a little jealous that we were doing this because I think they have some money in the VA budget right now. So if I would prefer to send him over to here first before we have him buy a new fancy piece of equipment. But it really feels like the VA would be a prime hunting ground
I
for.
was going to tell you, we do to start everything as the VA and then flow it here.
Well, there's just so many nodules there, right? And
Yeah.
but
Plus, not only that, we can create a good, it's a control setting where it goes through just 2 groups. Whereas here it's from everywhere else. So it's a little crazy.
yeah, I mean,
Just sort of you end up finding out the challenges, everything which you can later resolve here.
Totally.
They have a good setup, and I've enjoyed doing things.
Yeah, I'm very interested in this. I think I may have talked to somebody about this in the hallway, but I'm sure you guys have podcasts for endocrinology as well, but for interventional radiology, there's podcasts, and they interviewed the guy who's done 50 of them. So that tells you how many you have to do in America to be, he's at OHSU. They got a start before everybody else, right before COVID, and he's only done 50, right? So that's, I mean, I would guess that we have more than that around here that we could do quite easily. But
Patients ask for it.
yeah,
Sometimes.
I'm super ready.
I had to send a patient to Johns Hopkins three years ago because she only wanted this, didn't want surgery, bumpers, and I tried to. So then I had to look up, and then I talked to one of the members in ATA, and then referred her to Hopkins. Because at that time
There's nobody doing it. Yeah.
Yeah.
I
3.5 years ago, early pandemic.
So yeah, I would love to do these, to publish on them. I think I would probably insist on having them see you guys first, if that's okay. That's kind of our relationship with hepatology, is if we're going to do anything to somebody, we do a TIPS, if we do a TACE, we have them see the medical specialist first.
Sure.
And that way we're all on the same page. If you guys are too busy for that, I don't want to generate too many consults for you.
We are happy.
But yeah, I would like to have, I see this as a, we need each other, right? It's a symbiotic relationship.
It works well for the patient.
Well, they need to have somebody that, knows. I've been, I had to relearn how to say methimazole, right? I'm not even sure if I'm saying it right. And like all the PTU and those kind of things. Pregnant women is another one that they talked about. They don't want to do surgery in. I don't know why you'd have to have something done on your goiter while you're pregnant.
Seldom.
The other thing is that if they have a pacemaker, I probably have to involve anesthesia, because the way this RFA works, it's only a monopolar right now. So we still have to put the pads on the legs, and the current goes through the pads on the legs, and it can alter the pacemaker.
Oh.
They have bipolar that are out there, like what the surgeons use, Chicatery, but it's not FDA approved in America yet. So when it is, I have no loyalty to this company. We can jump ship and get a better one. But it's great. It's just like a little pen that just burns things. Yeah. All right.
Thank you so much. Thanks.
Nice to meet you guys. Yeah, I have.
Your time is so precious during daytime.
Oh, no,